articulator. Whew, right? But still my beating heart. I totally love my articulator. Could not practice dentistry without it. But we're going to be talking about how the use of an appropriate articulator will make things more precise, and how by having that precision, being able to consistently reproduce these beautiful records, how that's going to make our life better, reduce stress, and hopefully you'll see how it can start to enhance some patient care. So, obviously, you're on a Dawson Academy webinar, so you have to see a picture of Pete Dawson. And this is his guiding philosophy for me, which is the Whittiam rule. Would I do it on me? And I follow this rule every day with every patient. And I want to do the least amount of dentistry to solve the patient's problems. And like I said, that's one of our guiding principles. So even though sometimes we're doing these really complex, really, really large cases, we always have it tucked in the back of our mind that it should be the least amount of dentistry to solve the problems. And it should be what the patient wants and needs and connects and asks for. So I thank Dr. Dawson for that all the time. It seems to work quite well in my world. So in our practices, and just so you know, I practice in Louisville, Kentucky. So forgive my accent that appears and disappears at random times, but it is there. Small private practice. It's a fee-for-service practice, but I have practiced in almost every capacity you can imagine. DSOs, public health, academic realm. I have not done military world, but pretty much everything else I've had covered. So if you have questions, feel free, because I do believe you can practice Dawson dentistry in all of those. But whenever you're looking at your patients every day, you basically have two different types of patients. You have patients where their teeth look great, things are working for them. Maybe they have some caries, maybe some gingivitis, that sort of thing, but they don't have any major issues. The teeth and their form and their function, it's pretty good. And then you have the other people who are like train wrecks. And it's like no matter what you put in their mouth, things break down faster. It's like put in a filling, it chips. You put in a crown, you got to adjust the bites. They come in and they have oral facial pain. We divide these patients out into general patients or our specialty patients. And learning how to identify these folks and go through a proper treatment planning sequence is key to having a successful practice and not have emergencies like ring your phone off the hook. So the process of complete care dentistry is taking care of our patients from start to finish. It all starts with the exam and records. And that's how we really find out, is this patient, this general patient, is this patient a specialty patient? A complete exam is a little bit more than what we tend to do, what we were taught in dental school. Once we have that complete exam and an accurate, true diagnosis, then we can have a conversation with the patient and ask the patient if they're looking for solutions to their problems. And if they are, then we invite them back for a records appointment. And then we obtain a lot of the stuff that we're going to talk about today. So that way we can go through the 2D, 3D treatment planning, develop our options, and then we take that for a test drive and provisionals or transitional bonding. However, we're going to kind of put the patient in like our test run, and then we go into our definitive restorations. And when you follow this like process, you end up with really exquisite, complete care that's predictable and amazing, actually. And so anyway, going back to that complete exam and records, the big differences from what we do day in and day out, what we were taught in dental school, is that you have to do a thorough TMJ occlusal exam, which means more than just asking the patient if their jaw clicks or pops, hoping that they say no, but if they say yes, responding back, does it hurt? And if they say no, then you're like, yes, I'm off the hook, right? And if they do hurt, you're like, I don't know what to do with these patients. You need an acute acrylic deficiency scenario that you need a bite guard, or, I'll refer you away. So really getting into like the nuts and bolts of that. And we spent a lot of time at the academy teaching you how to diagnose these issues and do this TMJ occlusal exam. In our exam and records course, our foundations too, that's what we do, our core two. We always take a full series of photographs on our patients who are wanting solutions. Now, I will also argue that we should be taking a full series of photographs on all of our patients as part of the new patient exam process, because nothing will help you track how a patient is doing over time, as well as photos. I mean, intraoral scanning is coming really, really close, but when a patient can see their own face staring back at them, and watch the teeth change, then you tend to really grab their attention. And then advanced records and imaging, again, as it's needed when we're going to solve those problems. And those three things, it's kind of the core and the heart of the academy and what we do. Because in reality, when we start looking at a TMJ occlusal exam or just the system in general, we have to realize that all occlusal analysis is going to start at the joint level. There is no way to escape it. You know, the mandible is one beautiful bone that has teeth in the front and two joints on either side. And what happens at the joint level will affect what happens at the teeth level, and what happens at the teeth level will happen or have a cause and effect relationship on what happens at the joint. So you can't exclude one without the other. And having said that, we often talk about a term called occlusal disease. So occlusal disease is the most common destructive dental disorder. This is the disorder that patients have come in for routine care repeatedly every 6 months for their entire life, maybe had one filling, two fillings, nothing significant, yet they have eroded and worn their teeth, 50, 60%. And by the time they start to reach 50 or 60, they don't like the way it looks. Maybe things are starting to get sensitive, or back teeth are starting to crack now and they don't know why. And we have just watched that process happen over time. It's the number one factor that contributes to eventual tooth loss. Again, the need for extensive dentistry. Number one reason for pain and discomfort in muscles, teeth, and jaw joints. So this bite disharmony scenario, it has to be addressed. And I love this one, that occlusal disease is the number one factor in ortho instability, relapse, right? We use retainers to help hold patients often in malocclusions, where if we correct the malocclusion and we have the bite balanced and we have achieved all the goals of a stable bite, patients rarely will have significant relapse. Now, we can sit here and argue and debate like a little rotation here or there because you needed to break through fibers. Yes, maybe. But in general, everything is going to work really well. Tooth soreness and hypersensitivity. This is so true. There's like a puff test that you can take cold air and just puff on a really sensitive tooth. When you get that tooth out of traumatic occlusion, that sensitivity immediately goes away. Not days later, immediately. So by the end of the appointment, you can have a patient not have any sensitivity on their teeth. It's also the reason why a lot of teeth patients come in with tooth pain and then they end up going and having root canals. And then they have root canals that after they've had that done, the tooth still hurts. I'm sure we've all had that happen. It's because the endo wasn't the actual true problem, right? It was actually a malocclusion. And then it's, again, the most undiagnosed dental disorder until severe damage becomes too obvious to ignore. And the way we start to see this, what we train you to do at the academy, is we talk about signs and symptoms of instability, right? A patient could have the most horrific bite in the world, right? Bite on one tooth, everything else is gnarly, it doesn't matter. If they aren't bringing those teeth together and they're not exhibiting signs of instability or symptoms of instability in the system, we don't have to go and do things unless they want to. We're going to look for wear, mobility, migration and splaying of teeth, sensitive teeth, again, cold sensitivity or just sensitive teeth in general. Things cracking or breaking beyond just being a large alloy and they, bit on some piece of candy. Abfractions where the tooth actually flexes and bends because teeth aren't really designed to flex and bend. Sore muscles, TMJ instability, and the list goes on. And so much of what we deal with every day, day in and day out, are actual problems within the whole masticatory system where things are just out of whack. And people just need a little bit more balance, but not everybody. So that's pretty key. So I'm going to give you a picture because I'm sure you would see this patient in your practice today and you'll see him in your practice tomorrow and every day thereafter. But this is what earlier, I won't say early, the earliest, but what early occlusal disease starts to look like. You see wear on the anterior teeth, right? You see that lower arch starting to get a reverse curve smile, right? You can start to see that sometimes those wear facets look like that they're going to actually line up. Here's a picture from the front. But otherwise, very few fillings in his mouth, not a lot of gum disease going on, occasional gingivitis that he'll battle. But here's the thing. I want to catch a patient like this or even earlier and get them stable so that they don't turn into this patient, right? We don't see these as often as the others. But I mean, this guy's basically turned into a dental cripple. And had we been able to get him at the point of the prior patient and stabilize the system, we have done an amazing thing. So, once we've done the exam and we've talked to the patients and they want to have some sort of solution to their problems, then we have to figure out what we want to do. So we have to get to treatment planning, right? I love treatment planning. It is the most fun and creative process that we have to me in dentistry because I have so many ways that I can solve problems. I just have to figure out what's best for the patient. We've got tons of materials. We have lots, right? So when we get to this treatment planning process, this is the meat of how I'm going to have precise information. We're going to go through each of these. We're going to get all the records I need for an occlusal analysis. So we actually code that as occlusal analysis on mounted models. So yeah, there's a code for it. We're going to take the Dawson series, full photographic series. So what you're going to see there are 21 photos that we take the same way every time. And I will tell you, we'd love for you to be able to delegate that to staff and let your team help you take it. So I love team members to learn this process because they're often better at the photography than the actual doctors are. But we're going to take this photographic series. We're going to take an actual face bow right here, right? We use the Slide-O-Matic face bow from Whitmix, which is a very easy face bow. We'll talk about it a little bit later, but without a face bow, you're not going to be on the actual arc of closure, and what you create in any sort of a wax up or any sort of models, it's not going to translate to what is actually happening in the mouth well. And so what that means for you is that you're adjusting or grinding on your crowns or your other work. And we don't want to do that. No one feels good at the end of the day when the patient sits down and they're getting a new crown and you spend 30 minutes or more adjusting the context and the bite, right? No one feels good about that. Next thing that you're going to really need, exquisite, exquisite impressions. Okay. Again, we have a variety of materials. Alginate can be very great as long as it's handled well and poured appropriately. But in our realm, we tend to try to lean towards more doing like a polyvinyl impression. Think like Invisalign type impression, 2 steps, base putty kind of a scenario with a wash, to really capture all of the landmarks that we need, full up to the buccal folds. We need the palate. So even with an intraoral scanner, and I love my Trios 5 like a lot. Now it would be very hard to pry it from my hands. I am just going to tell you that you have to make sure that you're scanning and capturing all these additional landmarks. Like you have to have the palette. You want to capture as much of up to the buccal vestibule. That's the vestibule. Say that 3 times real fast. So that way, whenever you're making different matrices for your provisionals and for your prep matrices to make sure that you're prepping adequately and not over reducing, we rely on some of those anatomical landmarks for those to fit well. And so if you had just an impression where you captured just to the gingival margin, you're not going to have the predictability that you would have later. So even in your intraoral scanning, you need it to look like what it would in your subtly overextended, if you will, polyvinyls or alginates. And then on the bottom left, that always looks like somehow to me a Millennium Falcon, that little blue bite record. That's using a wax called Dinar wax. Used to be a Delar wax. They are 2 different companies, so you sometimes hear those used interchangeably. But we take a centric relation bite record, and we have just the cusp tips in this blue material, which as you can tell now has cross arch stabilization. There's a reason why we use it. It gets brittle hard once it's chilled, but whenever it's heated, it's dead soft. So you pick up a lot of good information, but we really only want the cusp tips. We don't want to get into the occlusal grooves. Again, now with better impression techniques, better stones, and digital models, if that gets a little bit deeper, it's not as hard, but some of the most inaccurate places on our models, if we capture soft tissue or the occlusal grooves, that's where we would have most of our bubbles and blebs. So we could not transfer our bite record to the models and duplicate those accurately. Previously, we can now. I mean, look, this is amazing stuff. So the goal is to actually have a mounted set on a semi-adjustable articulator. And we use the Dinar 300 series, 320, 330, which is beautiful, and you want them to look nice and presentable. And then and we use at the Academy, our software called the Smile Wizard, smilewizard.io if you want to go check it out. But it's going to help take you through a series of checklists as we plan. But checklists are great if you don't have an accurate record to start with. We don't have good photographs. We don't have good records when we get to the three-dimensional part of this treatment planning where we're actually waxing up the teeth. When you translate it to the mouth and it doesn't fit, it's really disheartening. It makes you work harder, it makes you sweat. But when you follow the process that we teach you at the academy and you pay attention to each step, because of course that's the most important one, right? And as you pay attention to that, you just build in such precision that everything fits and everything works. So whenever you go to deliver from your wax up to your provisionals, they just seat. They go where they're supposed to go. And then we take in our approved provisional model. And when we deliver our definitive restorations, they just fit. They work. It's none of the stress and strain that sometimes can happen. Point to note, in the analog world, you want to have two sets of these models, not just one. Sometimes that gets a little overlooked. And you want one to keep as an original set, and then the other one that you will like do your work on, just for legal issues. I do like digital treatment planning for that now because you always have an original untouched set. I will actually sometimes scan my old models or scan my models just so I have it as well. But once you've gotten all of that, like I say, we're going to sit down and we're going to go into our treatment planning. So you have to gather all of the records ahead of time to then be able to sit down and start to think about the case. Whenever we're sitting there and we're with the patient, we shouldn't be jumping to what's the vertical dimension. I'm going to have to open them up about 3 millimeters to solve this case, or I'm going to have to do this or that. Don't put yourself through it. I let my patients know up front, I don't have all of the solutions for you right now. I need to study your case so I can come back and present to you the best, most conservative treatment that's going to solve the problems that we've just talked about. And then I'll usually tell them the problems. And they're like, great. I don't really get pushback from that, as long as everything is done in a reasonable time. So then we use what we call the 2D and 3D planning. So 2D is us going through the chart, going tooth by tooth and looking at those photos and making decisions that we then later carry over to the models. So we don't just hop in on the models and start grinding on teeth or doing whatever we want to do. We do this very methodically each and every time. And so you basically have the 4 stages of optimum care. We have our 2D checklist that we're going to see, our 3D checklist, provisional checklist, and lab communication. And all of it hinges on your articulator. Did you get that? Hinges? That's pretty corny. I like it. I didn't even plan it. So with the articulator, as we start to go through some of that a little bit more, I just want to encourage you to understand how using the appropriate articulator, a semi-adjustable articulator with a face bow and an accurate centric relation bite record when you're going to start planning these cases will help minimize adjustments to work. How it helps you verify that you are in centric relation, that it's not some mystical place, that you can be taught how to find it repeatedly. And then how that brings, obviously, your treatment planning predictability and precision into place. So right now, this is a patient comes in your door. You're in hygiene, taking a peek at him, or he's a new patient, doesn't matter. But this is the issue. We have some decay. Almost every one of us has already probably formulated a treatment plan for that tooth, right? You will think new restoration, inlay, onlay, crown, right? Whatever it is that you're thinking, you could totally be right. You have to know what you need to do for the individual teeth. But what happens when it's in this mouth? This is one of the patients that I was telling you had come in routinely, never missed a dental appointment in his life, would do whatever you told him he needed to do. And that's what we did to him. I mean, it's like dentistry did him dirty. And it bothers me because we allowed this to happen to that patient. So, in your own mind right now, does that change how you're going to address the single tooth that needs treatment? And, we'll talk about second molars and things like that in a moment, but God, love, really? Like, okay, let's put a zirconia crown on there, right? That's what everybody go to. That way it'll be unbreakable. In the rest of that system, the system's not working. So in dentistry, we tend to have these typical articulators that we all see, little clap, clap articulators. And the reality of these is that they're not articulators, they're model holders, cast holders, if you will. They have zero bearing on how the jaws actually open and close. And so what ends up happening is you get contacts in totally wrong places, not where it's intended. Um, if you ever do an anterior case and they deliver it on an articulator like this, you're going to be adjusting the lingual aspects of those crowns, unless your lab completely takes it out of occlusion, which is terrible because then the other teeth are going to shift and drift and possibly anyway into that space, and you've lost control of the scenario. Um, so I don't like to see these. I don't like them to be used, especially for anterior cases, but even for single unit crowns, I find it's nice if you give the lab more information. Um, the big thing with a semi-adjustable articulator is that you get that opening and closing arc of the hinge axis of what the jaw is doing. So as the mandible is opening and closing, it's more accurate and closer to what's in the mouth. And the closer that we can get to the hinge axis with an ear bow, it is subtly arbitrary, but it's close, clinically significantly close, versus the clop clop articulators. In no patient that I have ever seen, or any human being have I ever seen, is the jaw joint directly behind the lower molars, right? It just doesn't happen. So the teeth don't go straight up and down on this little clop clop. They arc forward and close. So imagine this whenever you see an articulator, right? We're duplicating the patient's mouth. And this is a bite effects animation, which I love because it will start to show you um, the differences. Obviously, semi-adjustable articulator on the left, right? Clop, clop. If you add a contact, say on the second molar, it's going to fit in your clap clap articulator, but in the patient's mouth, it's going to be a high spot. So these are, different types of errors in the literature. You'll see positive and negative errors. So the lab technicians know some of this happens, and they try. So the more astute your lab technician is, they know what's going to happen if they add material in those areas. But if we just give them a face bow and even just a face bow and a good bite record, depending on the scenario, if they're a general patient or if they're a specialty patient, if we're going to work in MI or in centric relation, if you give them the appropriate records, then you don't have any of this. Is it going to fit? Is it not? Um, so the way we have to do it again is a face bow. A face bow takes approximately 2 to 3 minutes to complete in the office. Chair time, it will save you 10 times that, period. I'm going to just say that's the way it goes. Um, I can train your team members to take a face bow. It's a delegatable task. You can train your team once we've trained you and you've come to the academy. So, a face bow, while there are many types depending on your articulator system, it is invaluable to get, again, as close as you can to that hinge axis. Second molars for you guys. I didn't make this as a poll because we only had a little bit of time, but anybody out there struggle with like second molars? I will tell you, when I see consecutively on my schedule, like number 18, number 31, 15, and it's like it's all prepped on the same day. And it's not in someone who's had a balanced, equilibrated mouth. Yeah, this is what I want to do. I call it like a butt pucker. Right? My butt just kind of puckers, but I like love to just stick a fork in my eye. I cannot stand seeing second molars on there. And I want to say why, because this is why we're doing things in centric relation. I don't know if y'all are on social media, but this is from Joseph Young. He did give me permission to use this from the bench. But he posted this and it made me laugh. Happy birthday, like this case, stay tight and close to family and friends, however you celebrate. A round of Pinot Noir for everyone. So here is a lab technician putting up a picture of what they see day in and day out. There is no adequate reduction there, right? There is no restorative material that can have a 0.1 clearance. If you all know one, let me know. But what cracks me up is what all the other technicians replied with, because this is like us looking in a mirror. Can you make me a reduction coping for my birthday? For you, I'd perform some plasty on the opposing virgin tooth. by a couple millimeters. Um, your articulation has to be wrong. Temporary had plenty of room. And I don't understand. She had a crown on there before. And so, you know, technicians, God bless them. They they take a lot of heat from us and a lot of the stuff that we blame them to our patients, whether or not it should fall on us. We need to again look in the mirror because a lot of it does, and we can and should do better wholeheartedly. But this is not just one picture. This is, I mean, it happens every day. And if you're true to yourself, it happens to you. These are the patients that you prep the second molar, your assistant makes the provisional, then patient leaves. Well, then they're calling you because the provisional has come off. They're calling you because it's super sensitive and they can't bite down together. They crack the temporary. Now like their jaws are really, really sore. They might have trismus. It's just like the scenario, those signs and symptoms of instability come back and bite you on the butt completely. And so the reason why it happens, we'll watch in another bite effects animation, is that if the teeth get in the way from the jaws to seat completely, right? And then the jaws seat whenever you prepare the crown and you take the existing crown off, or you reduce a tooth by 2 millimeters, you're going to actually remove the interference and the jaw seats back and it seats into its appropriate place. And now suddenly you have zero space. So we should not wonder why this happens. We should actually be preparing our patients that this is going to happen. When you start doing complete exams, part of that and that TMJ occlusal exam is knowing what the first point of contact in centric relation is. Because if I'm going to have to prepare that tooth and we're treating this patient in maximum intercuspation, I am going to change their maximum intercuspation and I want to tell them ahead of time, right? Because whenever I prepare that tooth, I'm either going to have to prepare more to the level of how much there was a hit and slide. I'm going to have to adjust the opposing. Patients need to know that rather than us just going in and playing whack-a-mole off of a cusp. So anyway, I'll get off my soapbox. But this is the sort of stuff that happens. Patients come in and they crack and they break things and chomp down on some materials. And it doesn't matter. That was zirconia, it will break. So at the academy, we teach you, and even when I'm teaching the assistant class, I will actually teach the assistants about this as well. And the concepts of complete dentistry and the joints, the anatomy, all the signs and symptoms of instability. So we go over it like in a lot of detail. But, burn a picture, or as Dr. Dawson would say, burn in your squash, this idea of what the jaw should look like and how it should function. And we treat it ad nauseum. The thing you have to realize, as all joints have a home base, so does the joints, right? And the left and the right joint need to be in their respective sockets, right? And so sometimes you'll have some patients that have hit and slides where the jaw hits on back teeth and then drives things forward. And then there are other patients who actually the jaw hits on one side. Maybe the left side didn't grow as much as the right. But there could be lots of reasons, but then they develop into this malocclusion where they have a hit and slide and the jaw just literally shifts horizontally. So learning all of this sort of stuff is key. And when you have those instabilities, the muscles play tug of war with the disc, and they work against one another, and you end up with a lot of muscle pain or tightness, discomfort, which can then, for some people, if they're predisposed to it, create some stress and strain on the TMJ, the disc itself, which can then create even more problems. So, centric relation, it used to be a lot more argued 20 years ago, like whenever I came into dentistry. There were lots of definitions in the glossary of prosthodontic terms. Now it's back to the one definition from Pete Dawson, but it's a normal, happy condyle disc assembly. So not degenerative joint disease, nothing breaking down, everything is healthy. It's in the most anterior superior position. And it's not a tooth-borne position. It is an anatomical position that's there by bone and muscles. And it all has to work together. And so we teach this, the centric relation load test, to verify that the joints are healthy and capable of accepting load and to figure out then where the first point of contact is. So it's also how we take our bite records. So you'll see this like double hand motion, romancing the mandible time and time again. Hi, you all. This is Hank. He's going to come say hi now. But you're always going to ask, are there any signs of tension or tenderness? We're not saying pain. Is it uncomfortable? We're not shoving the jaw back. We're mimicking the muscles of mastication, and we're load testing a load-bearing joint because the jaw is a load-bearing joint. And we're asking if there's any signs of tension or tenderness 3 times. We start off very, very gentle, then we go to a medium pressure, and then we go to a firm pressure. We just don't pounce on a patient because that could actually hurt them if they have an intracapsular problem, and there's any inflammation or swelling. So you always start like almost feather light. And this is what it looks like in action. So here you're along for a ride, and you're asking the patient, do you have any signs of tension or tenderness in either joint? They're like, no. So then more pressure, same question. Third time, more pressure. And they say, no, no, no. You close down the first point of contact, hold there, and then squeeze those teeth together. And then you record their hit and their slide. Some people, it's more magnificent than others. So it's kind of fun. The magnitude of the slide does not necessarily correlate to more pain in any way, shape, or form. Sometimes we'd like to think that. So, a hit and a slide, again, in of itself might not be a problem, but if there are signs of instability, symptoms of instability within the system, then we need to take a further dive. But it doesn't take days, even though we spend days and days teaching you how to do this skill. You can see it only takes moments. But again, just to drive it home, when the jaws are pulled forward because the teeth are holding us forward to get into maximum intercuspation, and now we go back and we seat the joint fully, you'll end up with posterior tooth contact almost always and an anterior open bite. And that can go straight forward or side to side. And when we're planning our more complex cases, our starting point is going to be centric relation because it is the only way that we can reproducibly and reliably, right, and precisely create a stable occlusion that is interference free. Because if the jaw is pulled forward and then you build an occlusion to that, well, they might be stable enough when the jaw seats every time they swallow. At the end of a good chewing stroke, when we know that the muscles fully take the joints to that full seated position, then you're going to have occlusal trauma on certain teeth, or some weak part of the system will start to show signs. Mobile teeth, that's why we get a lot of second molars that are mobile or second premolars. Anyway, I won't bore you with more. Come to our classes and learn. But anyway, so we take our bite record at that point. It's an open bite record that we take, so it's irrespective of vertical dimension. But we want to be relatively close on that hinge. So, bite records are typically 2 to 4 millimeters thick, but you don't want a tooth to touch to start muscles activating. And then we teach you how to trim the wax and how to manipulate the wax and how to love the wax. But you want to see tooth, wax, tooth. And I'm going to tell you, if you use polyvinyl siloxane, you would want to see tooth, bite registration material, PVS, tooth. That doesn't change because when we move over to our models and we are actually in the lab mounting our case, we have to know that that bite record fits exactly on the models as it did in the mouth. Again, this is part of the precision, right? If there's any rocking, if it's not fully seating, if suddenly in the mouth everything fit perfectly, but on the models there's space, right? Likely we have a distorted model. With scanning, less, polyvinyl, less, but it still happens. Even in our exam and records courses, I will see distorted models still come by, and that's really disheartening because then you go through the whole process and you feel like I've got a great handle on this. And then you go home and you take a record, and because the model's inaccurate, now you're second guessing everything. So again, every step is the most important step. Sandino, Dr. Costa has what programmer do you recommend? We use Elucia Jig from Great Lakes Technologies. I also have used the Denard deprogrammer. It's a little bit wider of a platform that is made by Whitmix. So either of those. The wax comes from Whitmix, the Dinar wax, and it has a cutout already made in the anterior area, which would account for enough room for either deprogrammer. the Lucia or the um, Denard programmer. So it's a good question because we do teach you how to do that. We spend days. And then every course that you come back to, if you do our entire curriculum, we will put you back in the chair and like everybody gets to redo bimanual manipulation and we revisit all of these skills. It's a super important skill to be able to do. So again, you want your mounted models to duplicate as best as possible what's in the mouth, okay? Because that's where true precision really just comes from. So again, has to fit. When I'm teaching the assistants, we go over this and I train them that if they go to put this model, they'll check the bite record on the maxillary model, they'll check the bite record on the mandibular model, and then they'll put the two together. And if there is anything that does not look like tooth wax tooth, I train them to come and bring it back to you, the doctor, and ask what you would like done. And then I also train them that they should encourage you to get the patient back for a better bite record because I'm that kind of a nice person. We don't like to fudge it and make it fit. And the beautiful other thing about this material, I said it was brittle hard whenever it's cold. If you try to squeeze your models and make it fit, it will break. You can't do it. It will break. There is no give to the material. So it's a cruel learning lesson sometimes. But here's the fun thing too. So in exam and records in our curriculum, you actually go through a process where you can take multiple bite records for your patient in centric relation to see that you can indeed have the reproducibility, right? That precision, that with a pinpoint accuracy that we can actually find and record, and then transfer to models, centric relation. It's huge. So literally like with pinpoint. So here's a little video that's going through it. Not that I expect you to know this whole video by any stretch of the imagination. But in essence, you put the centric check pointers on, and you have the lower model, mounted model already in place. And then there's like a couple little flags that you put on this special upper model member. And then you put the bite record in place. And then you hold all of that together. And then you're going to take that little pinpoint through this flag, right? And then you'll do it to the other side. And you could have 3, 4, 5, 10, doesn't matter how many bite records. And this particular centric check, it's not dependent again on vertical dimension. So it's all on the arc of closure. So being that that's a pinpoint place, you can take multiple bite records, different vertical dimensions, still put it on this articulator, and you'll find that whenever we're in centric relation, every one of those little pinpricks will be in the exact same space. Like it's 0.1 millimeter or less accuracy. Each one of those little grids is about a millimeter. So when it just perfectly goes through on either side, you can start to feel confident that you are in the right spot. And, if one is down and forward of the other mark, then we know that you probably haven't gotten full release of the lateral pterygoid muscle, one of those muscles that's responsible for pulling the jaw forward, the only little strap muscle about as big as my thumb, really responsible for pulling the jaw forward and holding it into maximum intercuspation. Sometimes we'll actually see that the mark is down and back. And that means we've distalized the condyle. We've pushed back too hard. And because centric relation is the apex of force, the most superior position, any miscentric relation is going to be down. So down and back or down and forward. So you get to start to see that. And I have probably helped over my going on 20 years, I don't know, hundreds now of these records courses. And the fun thing is to watch 6 doctors take 2 or 3 bite records and end up having pinpoint accuracy. So that's why we teach what we teach, right? It's a great starting point because it feeds right into the treatment planning predictability. So the treatment planning for optimum outcomes, I'm going to put down there that big key. Is it maintainably healthy? Sometimes we get into heroics and we try all sorts of things, and what we realize is that the patients can't keep it clean. It was a huge thing that Dr. Dawson would talk about. But I want maintainably healthy in the minds of aesthetics, function, biology, and structure, right? We want to make sure that we check all the boxes. When I first learned how to do this, I'll be honest with you, we didn't have as strong of the aesthetic component in our checklists. So I would make these teeth that were quite functional and they solved a lot of problems, but they look kind of ugly. They look like little triangles or like little boxes. And I was like, that's not so great. And so by the time we refined our process and started adding in the aesthetic parts to develop our 2D, 3D checklist and put it together, you end up with beautiful looking teeth that function well and are stable and strong. And occlusal goals are very simple. And I actually find it, sometimes we say there's five. I simplify it to three. Stable, equal intensity stops. There are camps out there who tell you that you want to have lighter occlusion on the anterior teeth. We don't say it the same way. We want stable contacts everywhere, but we don't want teeth that are being beat up, which we'll come to in a moment. Creating non-interfering posterior teeth. So all the teeth should touch, and anytime that you're moving away from your bite, you should have, and working and non-working and protrusive, back teeth get out of the way and everything is as far forward as you can get. Obviously, canine forward is what we would love. Sometimes we have to do a group function a little bit more than that. But the big thing is also everything needs to be in harmony with the envelope of function. So this is where I think some of the other camps will start to say, well, no, we want to have those teeth just out of occlusion. We want them touching definitively. Everything equal all the way around, even with a T-scan, right? Everything hits evenly and in timing. But we check for things like fremitus, like where you have your bite and you're like, do I feel the tooth move, wiggle? We're looking for a nice smooth anterior guidance where you're not feeling bumping and that everything is nice and smooth. Because that's how we start to have some of those problems, not just because the tooth is actually touching. So whenever I see an orthodontist finish cases routinely without anterior tooth contact and try to come at me and tell me that, I'm like, you're wrong. Because if the front teeth don't allow for an appropriate immediate disclusion of the back teeth in left, right, protrusive, right, then you're going to have increased muscle activity and problems, potential problems if they play with their teeth. And so, having gotten to the point where we have like accurately mounted models and we're sitting down and we're going through our checklists, we're finally getting to the meat and potatoes of this. Now we're in like our third course, if you will. I told you I love treatment planning, that we have tons of ways to do things. Really it boils down to four. We can reshape teeth, we can reposition teeth, we can restore teeth additively, or we can reposition bones. We can do surgery, segmental, full jaws, that sort of thing. We do joke about the fifth R, which is refer. You gotta love that one. But even within reshaping, I have a lot of leeway of how I'm going to do things. We don't always just equilibrate down to first points of contact. If people have hidden slides and wear, we actually utilize that space from the hidden slide to help build the teeth up without ever altering vertical dimension. So there's like all these like cool, fun, magical things. And when you sit down with the models, like your mind just goes, poof, I can do so much. But we have to guide it, right? So we're going to go through 5 requirements of occlusal stability, if the patient meets it or not. We're going to look at the global aesthetics using all of those photos that we've taken. Every single photo of that 21 series has a particular purpose related to the global and macro aesthetics. And so then we go into the macro aesthetics and we start to dial in. So we start globally and we get more focus. Each time writing some options of what we think might work for this patient. So if a tooth is a little short, I might say, aesthetically, to fill in the lip line, I would like to add about 2 millimeters to the incisal edge of this tooth, right? We look at a horizontal profile picture to say, all right, I got to be careful when that's being waxed. I don't want to bring that tooth too far out facially because they have a tight neutral zone. The lips are really, really tight, and I don't have enough room to flare a tooth, right? So you're looking with intent at those photos and writing really good detailed notes, because then you take that information and you transfer it to your models. Now, what did I tell you? You don't just start going to the models and grinding or adding wax or doing things. We actually methodically look at it, and we start with choosing our condylar position. right? So are we going to work on a tooth in maximum intercuspation or centric relation? Those are pretty much our two big choices. I would tell you, let's not do any 3D treatment planning in a treatment position. We save those treatment positions for patients who have a lot of internal joint derangements and we can't verify centric relation or an adapted centric posture. And we talk about that. There are red joint patients. I don't want to sidetrack you with that right now. But I would never really finish a full case on a treatment position. But then you're going to go tooth by tooth. And like that one case where it was the second molar and the whole mouth that was worn down, like I need to go tooth by tooth and know which teeth need to have a restoration. And I will write on my models R or C. I make it pretty simple. So that way when I'm looking at it, I know if that tooth already needed a crown or some sort of a restoration. I just put like a question mark on it for the R. Could I do a direct filling? Could I do something, different? Then we look at the occlusal planes, maxillary arch and the mandibular arch. If we start to see those like dive curved planes, then we're going to actually go in and we're going to wax up starting on the lower incisal edge and start to determine what we think our best plane would be. And then we go to the vertical and horizontal position of the upper teeth, right? We do the same thing. I add that 2 millimeters to the incisal edge. So now I've added to get rid of the reverse curve and I've added to the top. And now at step 6 is when I actually put them back onto this articulator and I start to look at, oh, am I going to raise vertical? Am I going to equilibrate down or am I going to use the space that I have? And then we fill in the wax up with all of our occlusal requirements for occlusal stability. So equal intensity stops, all that good stuff. So it's so much fun. I love waxing by far. And here's the thing. People are like, why do I need to use one of these articulators? Because it helps you, right? So I told you we needed to get everything as precise and accurate, right? Mounted on these models to duplicate as best as we possibly can what's going on in the patient's mouth. The cool thing is the articulator, the one that we use anyway, but any semi-adjustable articulator, you can have it set up so that it actually helps you, right? And so by that, we go into it again in the courses. We actually, in the mouth, have an articular eminence that is convex. On articulators, it tends to be a flat path, right? That convexity of the articular eminence isn't duplicated. So what that actually means for you is that when we're doing our wax up, if I can get disclusion of the teeth on the articulator, then in the mouth, the teeth disclude faster. So whenever you're starting to actually wax up your case, you want to see the teeth separate, but not crazy fast. There's a timing thing, right? Because in the mouth, it's going to go faster. So, we make sure that that happens. Same thing with going to your left and right excursive movements, if you will. We don't do any immediate side shift. Why? And I'm throwing this out there because we forget. Look at your Gothic arch tracings. It goes back to a point, right? There is no like flat part to it. It is literally a point. So that's what immediate side shift, if it existed, it would show you like slop in the joint, if you will, like left and right. It doesn't exist. The jaw rotates around this medial pole when it's in its socket. And if it's going to move left or right, it's going to come down. So anyway, that's what you see there. So articulators shouldn't have that in. Fully adjustable articulators, you have the ability to add that, and that can throw you off sometimes. And then you can have your progressive side shift. The most that they've ever actually recorded in a human being was 12 degrees. So on our articulators, it's set at 15 because then we know if we can get it at 15 degrees, whenever it comes in the mouth, it's going to disclude faster. So your articulator helps you. It's so beautiful. Love it. Then you work on creating the stable equal intensity contacts because teeth do not like to be hit on inclines. I always say inclines bad, if you will. I call it the mullet of dentistry, but it's lines in the front, dots in the back. You're going to hear that a lot. That's what we want to create the non-interfering posterior teeth because this causes so many problems. Even in the assistance course, we talk about this and we talk about how to actually start just adjusting like single teeth, making sure that your single tooth restorations are good. And then in the context of what it should look like for your full mouth. And so we create the anterior guidance in harmony with the envelope of function on wax, and we make sure everything looks amazing. And when we do that, You know, you have a patient like Charles who presents to you. Again, you know, he's not a general patient. Can we all see that? Sad thing again, he showed up to the dentist every 6 months for his life. And this is where he ended up. Um, but we go through our 2D checklist, our 3D checklist, take it into provisional prototypes, and then we go to definitive restorations. And Glenn DuPont, one of my mentors at the academy, who's since retired, but he says we always look at a case in 4 ways. So in your mind, on wax, you test out all of your theories in the prototypes in plastic, if you will, before you go to your final definitive restorations, be it glass, be it zirconia, be it whatever. Um, and so you end up, you know, predictably finishing a case. Um, Big thing about this, whenever you come through the academy, is we teach you how to do it the same way for every patient, every time, right? I love the quote from Tony Robbins. It's not what we do once in a while that shapes our lives, it's what we do consistently. And the checklists set me free. Once I realized I didn't have to answer all of the complex patients' plans and give them like a full treatment plan in like 3 minutes, once I just let that go and told them that I was concerned, and if we'd like solutions, we needed to study it, brought them back for the records, and then I would have them come back for a consultation and meet them where they were and repeat to them the things that they wanted to solve and show them how I could solve it. And then I had the confidence in the process, the precision of the models, like treatment planning, just case acceptance through the roof, right? And that's what I'd want for everybody. Because in the end of the day, you don't want to be in the office all the time, do you?